My name is Ali Khader. I'm a PGY4 radiology resident at Leahy, and I'm here to talk about our project titled Trends and Notable Findings of Non-Routine Communications. This is a very high-level summary, and there's a lot more detail not included. No authors have relevant disclosures. As per the ACR practice parameter for communication of diagnostic imaging findings, certain imaging findings require additional non-routine communication between the radiologist and clinical team beyond just the radiology report. In 2014, our practice implemented a system to assist in additional communication of actionable findings based on urgency as designated by the submitting radiologist. While there are general guidelines for submissions, it is not feasible to create an all-inclusive directive list due to dependence on clinical context. As our submissions fluctuate around 10,000 per year, this represents a significant administrative burden for both our department and referring clinicians, and we sought to ensure appropriateness of utilization. Our Imaging Management Center has staff to assist radiologists in the communication of all these findings, and the IMC operates in the hours listed here, and the IMC handles a myriad of communications at our institution, including critical value communications, unexpected or significant finding communications, image sharing, and legal correspondence. There are two categories of findings in our practice: critical and unexpected/significant findings. The critical findings are those defined by the Joint Commission requiring MD to MD communication within the first hour. IMC facilitates this contact between the clinicians as needed. Unexpected or significant findings, however, include those that are incidentally detected and would warrant further follow-up or additional workup. The workflow for these unexpected or significant findings are divided based on patient class, including ER patients, inpatients, and outpatients, with each having its own method of communication. Some questions we wanted answered included: what is the current practice at Leahy? What are the trends and categories of actionable findings being submitted at our institution? And are there any opportunities for improvement? For the method, first we analyzed a subset of submissions for the appropriateness of each submission. Then we categorized the findings in each submission. For example, whether it was a suspected malignancy, infection, or an iatrogenic cause. Finally, we took note of the rate of submission by each radiologist. Studies were extracted from a sample in the dates of August 1st through 23rd of 2021. During that time, there was a total of 1,105 submissions to the IMC for unexpected or significant findings. 500 of those were retrospectively reviewed for appropriateness and trends. Submissions were determined to be appropriate based on acuity, actionability, and completeness of interpretation, using all available priors and imaging tools. We categorized the findings into disease categories and subcategories and then further grouped neoplasms based on organ involvement. We also looked at the utilization of the IMC tool amongst the top 10 reading radiologists and the types of submissions they were more likely to submit. Here we have the algorithm for determining appropriateness of submissions. So going along the algorithm, for example, an opacity seen on a chest X-ray concerning for infection. We first see which category this falls under. In our example, this would be the infection category. Next, we determine whether this was seen on prior imaging or if it was a chronic finding, in which case it would not be an appropriate submission. If it wasn't seen, however, and it is an actionable finding, then this is determined to be an appropriate submission. Overall, submissions were nearly 99% appropriate, falling under one of the expected categories for unexpected or significant findings and potentially warranting further clinical workup. The two studies deemed inappropriately reported including communications of a finding found to have resolved since the prior exam and a chronic finding that had been included in prior studies. When looking at the pie graph on the right, studies were divided by patient class, with 56% being in the outpatient class, 24% emergency, and 20% inpatients. On the left here, we have categories of the top 10 disease etiologies reported based on patient class, and we have neoplasms, vascular, and infection causes as being the top three, with neoplasms dominating the race. Under the neoplasm category, The majority of them were in the outpatient class, and of those, the majority were for suspected malignancy. Looking at the pie graph on the right, the most common location for these malignancies were thought to be the pulmonary and renal systems, with further subcategorization of the renal neoplasms showing that 40% were submitted due to indeterminate renal lesions. However, of those, 10% had spectral CT imaging, which, if interpreted thoroughly, would have precluded further imaging. Here we have the top 10 submitting readers compared relative to the total volume read in the same time frame. We can see here the radiologist with the most studies read in this time frame had the lowest total submissions amongst the top 10 submitting radiologists, with only 1.4% of their cases submitted. Conversely, the number 1 submitting radiologist had some of the fewest cases read. 50% of the studies communicated led to additional workup and intervention. The quantity of studies read did not correlate with the total submissions to the IMC. Briefly here, we have a chart comparing the percent of studies communicated relative to total volume read between 2014 and 2022. As we can see, there has been a steady decline of overall utilization of the unexpected or significant findings submission tool. Submissions were 99% appropriate. Of these, inpatient submissions were entirely appropriate, ensuring that our busiest colleagues are not being interrupted unnecessarily. The most common submission was certain or potential neoplasm, ensuring early diagnosis and treatment of potentially devastating disease. Radiologists' rate of use of additional communication is variable, with differential utilization of the tool regardless of total volume read. It's expected that radiologists reading similar case volumes should be reporting significant and unexpected findings equally. However, this was not the case even within each individual department. Reasons regarding overall decline in submissions longitudinally are not clear and would warrant further investigations. Next steps include considering opportunities for improving patient care. For example, given the high number of specific renal and pulmonary neoplasm submissions, we can consider whether these should be shared with subspecialty specific patient navigators as well as ordering clinicians. We can also consider opportunities to improve uniformity of content and the rate of radiologists' use of additional communication. Thank you for your time.